Hello, thank you for joining me for the Purple Day celebration. I am Dr. Mackenzie Cervenka. I'm a professor of neurology at Johns Hopkins School of Medicine, and I direct the Johns Hopkins Adult Epilepsy Diet Center. Today, I will be talking about recommendations for adults with epilepsy using ketogenic diet therapies. Here are my disclosures. And here are the learning objectives for our session today. To define ketogenic diet therapies, to reflect on the evolution of ketogenic diet for adults over the last century, to discuss current international recommendations for management of ketogenic diet therapies in adults with epilepsy. First, I just want to point out that this past year, 2021, we celebrated the 100-year anniversary of the ketogenic diet. Here is the landmark paper that began that celebration 100 years ago on July 28, 1921, when it was described that 3 patients with epilepsy, ages 13, 23, and 31 years, were treated with a ketogenic diet at Mayo Clinic in Rochester and became seizure-free for 12 days to 4 weeks, and the ketogenic diet was born. What is a ketogenic diet? What actually would be considered a ketogenic diet? This would be any diet in which the liver produces ketone bodies as a fuel source for the brain. This can be achieved by either consuming fatty acids, which travel into the liver and are metabolized into ketone bodies, such as acetoacetate, beta-hydroxybutyrate, and acetone, which can cross the blood-brain barrier and be used as fuel for the brain. Or fasting can also produce a state of ketosis because the body is actually metabolizing body fat as a fuel source. I want to make a brief distinction between the ketogenic diet that I just referred to, that is now 100 years old, and what we now refer to as the keto craze, which has emerged over the past 4 to 5 years, which involves different diets that have been described as ketogenic. However, they may not actually be diets that produce ketone bodies. And therefore, in the medical community, we are now using the term ketogenic diet therapies, referring to any type of ketogenic diet therapy that might be used in the management of either epilepsy or other disorders that actually does produce ketone bodies and have a therapeutic benefit by doing so. Today, I will be talking about 5 of the ketogenic diet therapies used for adults with epilepsy. These include the classic ketogenic diet, the modified ketogenic diet, the modified Atkins diet, the low glycemic index treatment, and the medium chain triglyceride oil diet. First, the classic and modified ketogenic diets. The classic ketogenic diet is the one that was described initially 101 years ago. This classic diet is 90% of calories from fat and produces ketone bodies. Typically, this diet is talked about in ratios, and the ratio is the ratio of fat to carbohydrate and protein combined in grams. The modified ketogenic diet is a slightly lower ratio ketogenic diet, typically a 1-to-1 or 2-to-1 ratio of fat to carbohydrate and protein in grams. Foods are therefore weighed on a gram scale, and this is a rigorous diet. Historically, as you heard about, it can be started as part of a hospital admission over 3 to 5 days, and this is done typically with a classic ketogenic diet and most often in children. Patients may begin with a fast at the onset of the diet to promote early ketosis, and nutritionally complete enteral formulas are now available for patients who are tube-fed with epilepsy that may be appropriate for ketogenic diet therapy. Next, the medium chain triglyceride oil diet was proposed as an easier way to produce ketone bodies. Rather than eating 90% of calories from fat, 30 to 60% of calories could be consumed by using MCT oil. The advantage of MCT oil is that it can more readily produce ketone bodies, and this can come from coconut or palm kernel oil, and it's easier to make ketones with less fat. However, some of the disadvantages have to do with gastrointestinal side effects, such as nausea, diarrhea, cramping, And so therefore, this MCT oil has to be increased gradually over time in order to be incorporated into a diet. So nowadays, we typically will use this MCT oil along with one of the other ketogenic diet therapies rather than as the primary diet. Next, we have the modified Atkins diet. This is the diet that we use primarily in our center at the Johns Hopkins Adult Epilepsy Diet Center for patients that eat by mouth. It is typically a 10 to 20 gram net carbohydrate diet, and net means that you subtract fiber from the total carbohydrate intake in the day, and that you consume only a limit of 20 grams of net carbohydrates per day in adults and smaller portion in children, depending on age. Patients are encouraged and instructed to follow food labels to count their carbohydrates rather than weighing foods on a gram scale. So in some ways, this diet is less restrictive than the classic ketogenic and modified ketogenic diet. When looking at patients' food diaries of what they have eaten on this diet, it's typically similar to a 1-to-1 to 2-to-1 ratio diet, but less restrictive with regards to the exact number of grams of fat and protein that are consumed along with the diet. The purpose, again, as I mentioned, is to produce nutritional or metabolic ketosis, which I'll just point out briefly is not the same thing as ketoacidosis, which can happen in patients with diabetes. The ketone body production with these diets is much lower and less likely to produce side effects. Next, we have the low glycemic index diet or treatment. This diet also focuses on reduction in total carbohydrate intake and can be considered ketogenic. However, that is not the primary focus of this diet. The primary focus is to choose carbohydrates that have a low glycemic index. What a glycemic index is a measure of how quickly glucose levels increase in the blood after a food is consumed. So for instance, white bread has a very high glycemic index because the glucose level will rapidly increase after consuming white bread. And a food like hummus has a very low glycemic index because the glucose level will rise more slowly and over a longer period of time. And so this diet focuses not only on reducing carbohydrates, but also focusing on the types of carbohydrates that are being consumed. Now, this audience is very familiar with the management of seizures in patients with epilepsy, but just as a reminder and to put this into perspective as we talk about diet therapies, we know that the lifetime cumulative incidence by age 80 of one or more seizures is 9 to 11%, of epilepsy is 2% in the whole population, and the risk of seizure recurrence after a first seizure, or the risk that another seizure will occur, is 33% overall in the population, and after a second or third seizure increases to 70 or 80% without treatment, which is why we recommend treatment if the patient has had 2 or 3 seizures, and certainly if they're at increased risk of additional seizures. After 2 appropriate anti-seizure medications have been tried, we then look in clinical trials as what's called a responder rate. A responder rate is the likelihood of having a 50% or greater seizure reduction. And with current anti-seizure medications, that responder rate is typically around 40% for trying a third or fourth additional medication. Now, for patients with medication-resistant epilepsy that have a possible seizure focus, so focal epilepsy and an area where seizures could be coming from, could be potential candidates for epilepsy surgery, which is shown here. Diet therapies, which we'll talk about in a moment, and then also patients who either are not candidates for surgery or not ready to consider surgery could also be candidates for things like vagus nerve stimulator, or in some cases, patients may be candidates for a responsive neurostimulator. So these are just other examples of treatment modalities. Now, returning to ketogenic diet therapies, one of the earliest therapies that was studied for adults with epilepsy was the modified Atkins diet. Here is an early study looking at 30 adults who were treated with the modified Atkins diet who had drug-resistant epilepsy, and they were tried on it as adjunctive therapy in addition to their anti-seizure medications. As you can see, at 1 month and 3 months, 47% responded to the diet, and at 6 months, this had decreased to around 33%. Looking at further studies, including the classic ketogenic diet and the modified Atkins diet in adults, we saw responder rates in around between the 30 and 40% range. And the conclusion was that patients were responding to the diet. However, there was a difficulty with maintaining adherence over longer periods of time, such as 6 months by following diet therapies. There have actually been two larger randomized trials more recently comparing adding a ketogenic diet therapy, in both cases the modified Atkins diet, to standard of care anti-seizure medications, or comparing that to patients that continued a habitual diet. And in one study, the one that you see on the left, there was benefit, significant benefit over habitual diet. And in the other study you see on the right, there was not found to be a significant benefit overall with regards to seizure reduction. And so as you can see, some of the trials and studies are still mixed with regards to outcomes in adults on ketogenic diet therapies, but these results are promising in terms of thinking about larger studies to continue to evaluate this. At the bottom is a Cochrane review that concluded that randomized controlled trials discussed in the review show promising results for the use of ketogenic diets in epilepsy. However, the limited number of studies, small sample sizes, and the limited studies in adults resulted in a low to very low overall quality of evidence. Now, because of this, a group of international collaborators, including Sue Wood and I, who designed this study, reached out to a group to start to discuss international recommendations for ketogenic diet therapies in adults. And as you can see, we did a survey with these international collaborators and found that they had treated 2,189 adults with ketogenic diet therapies for epilepsy and other neurologic disorders. You can see here the stars representing the countries where these experts were treating patients. And here are some of the survey results. The most common ketogenic diet therapy that was used was the modified Atkins diet for treating adults with epilepsy. The second most common was the classic ketogenic diet, followed by the modified ketogenic diet, the low glycemic index treatment, and medium chain triglyceride oil combined with another diet. Now, as you can see, these numbers add up to much more than 100%, and that was because these centers were using combinations of more than one diet for patients, depending on their specific needs. There has been an excellent paper that was published by our pediatric colleagues looking at indications for ketogenic diet therapies in the pediatric population. Specifically, this review article in 2018 looked at indications where the diet was described as having reduced seizures in more than 70% of patients. So in other words, there were more than 70% who were responders with these specific conditions. And what I'll highlight here are a subset of conditions in which there could be circumstances that an adult either was not diagnosed as a child and therefore had not been tried on a ketogenic diet therapy. Perhaps a ketogenic diet therapy had not been introduced in childhood, or they start to have symptoms in adulthood, such as onset of super-refractory status epilepticus. Again, here's a second list of pediatric syndromes in which ketogenic diet therapies have been found to be particularly effective. And once more, here are some conditions in which patients could be diagnosed in adulthood, or perhaps were not offered a ketogenic diet therapy as a child, and this might still be an indication in adulthood as well. And so when we surveyed the experts, we found that there were a number of indications for which adults with epilepsy were being treated with ketogenic diet therapies. Glucose transporter type 1 deficiency syndrome is a genetic disorder in which glucose cannot be transported across the blood-brain barrier effectively, and ketone bodies can be used as an alternate fuel source. So this is considered standard of care management of glucose transporter type 1 deficiency syndrome using a ketogenic diet therapy. The group also used ketogenic diet therapies for anti-seizure medication-resistant focal epilepsy, and we'll come back to this topic again in a moment. For tube-fed adults with epilepsy, adults with juvenile myoclonic epilepsy who did not respond to anti-seizure medications, Likewise, adults with Lennox-Gastaut syndrome who did not respond to anti-seizure medications, or juvenile absence epilepsy who did not respond to anti-seizure medications. An interesting subset of about a fifth of centers also used ketogenic diet therapies as monotherapy in adults. However, I will just caution that there have not been clinical trials done in adults comparing an initial diet therapy to an initial anti-seizure medication. So we don't have evidence yet to be able to support that specific use. Recommendations with regards to diet selection, the groups all recommended that we consider ketogenic diet options based on tailoring it to the individual, specifically to patient preference, to support structure, autonomy, and mode of feeding. So for instance, feeding by mouth or feeding using a feeding tube. Here is a long list of absolute contraindications to ketogenic diet therapies, and I won't read through these. What I will point out is everything that is starred on the left. These are all severe metabolic disorders that occur typically in early childhood, and that's when they are diagnosed. So usually these absolute contraindications are not considered in adults who are starting to have seizures or who are presenting in adulthood. Now on the right are some conditions in which we do have to consider the possibility that an adult may have these and that they could be absolute contraindications to using a ketogenic diet therapy. Acute pancreatitis, liver failure because the liver is metabolizing the fat that is taken in during a ketogenic diet therapy, porphyria, and the group did feel that pregnancy is at this time an absolute contraindication just because we don't have enough evidence to guide us as to whether there can be birth defects in children born from women that are on a ketogenic diet therapy during pregnancy. Here you see a case series of 2 patients that we reported on that had healthy infants. However, this is not enough information that can yet support this use of ketogenic diet therapies. Relative contraindications, and that means times that we would consider starting a diet therapy with caution, include epilepsy surgery candidates. The group felt very strongly that if a patient with medication-resistant focal epilepsy was considering a ketogenic diet therapy, they should also be considered for the possibility of epilepsy surgery. The reason for that is the likelihood of becoming seizure-free after receiving epilepsy surgery in someone particularly who has a lesion, such as in this MRI here, where you see a patient that has mesial temporal sclerosis, can be up to 70% with regards to the chance of being seizure-free. The likelihood of being seizure-free by adding a ketogenic diet therapy is much lower. We usually, once again, think about it in terms of response rates or the likelihood of a 50% or greater seizure reduction. So we do encourage patients who are surgery candidates to go ahead and undergo that evaluation prior to starting or trialing a ketogenic diet therapy. History of pancreatitis, gallbladder removal, renal failure, kidney stones, these conditions can all be exacerbated or can be difficult to combine with the ketogenic diet therapy. So these are relative, not absolute contraindications. And then patients with type 1 and type 2 diabetes should be very closely followed by an endocrinologist because in reducing the carbohydrate intake, they will likely need a reduction in their diabetes medications, possibly insulin requirement if they're on insulin, and that should be a discussion with the endocrinologist. Here are some other relative contraindications. A patient with known osteopenia or osteoporosis, because this patient might have worsening of osteopenia or osteoporosis on a ketogenic diet therapy. Other potential contraindications are hyperlipidemia, cardiovascular or cerebrovascular disease, because these conditions are still being studied with regards to whether or not a ketogenic diet therapy is safe. History of anorexia, because the ketogenic diet therapy is limiting with regards to food intake, and this could exacerbate anorexia. Severe gastroesophageal reflux, or inadequate social care provider support and difficulty maintaining adequate nutrition. Here are the recommendations made by the international group regarding fluids and supplements. We recommended reviewing side effects such as fatigue, thirst, irritability, and hunger, as well as altered bowel habits, particularly constipation, and strategies for how to prevent or manage them. Increasing fluid intake can reduce the risk of many complications of ketogenic diet therapies, and in particular, constipation. Patients are encouraged to take a multivitamin, mineral, and trace element supplement that meet recommended daily allowances, and additional vitamin D3 and calcium supplementation. They are also encouraged to supplement magnesium, carnitine, and use antiemetics, citrates, and antacids only if they are symptomatic, not as a part of the therapy at initiation of a ketogenic diet. With regards to monitoring, typically we will obtain laboratory studies prior to starting a ketogenic diet therapy. And these laboratory studies are to screen for any potential contraindications that let us know that a patient should not start a ketogenic diet therapy. These also include a urine pregnancy test for women of childbearing age for the reason I mentioned, that we want to make sure not to initiate the therapy during pregnancy. We talked a bit about metabolic screening, which we do not typically do in adults because we anticipate that any severe metabolic disorder that's absolutely contraindicated would have been identified in childhood. We obtain serial bone density scans beginning within 5 years of starting a ketogenic diet, and in particular in patients who are at high risk for having bone loss prior to starting the diet. We monitor ketone bodies, and we do this either using meters with blood beta-hydroxybutyrate level monitoring or urine acetoacetate monitoring. We recommend this in the early stages of starting the ketogenic diet therapy so that patients can get feedback about ketone body production. However, we adjust the diet based on treatment response, minimizing side effects, and maximizing sustainability. So in other words, just like checking anti-seizure medication levels, we don't adjust the diet based solely on the levels, we adjust the diet based on how the patient is doing. With regards to maintaining the diet, frequent support from a dedicated ketogenic diet therapy team is essential. Here you see Bobby Barron, who is the registered dietitian at the Johns Hopkins Adult Epilepsy Diet Center, and is very important to have a combined team to foster knowledge, skills, and competence in adults managing their ketogenic diet therapy. We recommend a minimum of 3 months of ketogenic diet therapy before making a judgment as to the response to the diet. And the time frame for ketogenic diet therapy discontinuation is really dependent on the response to treatment. Just like with anti-seizure medications, we do not like to taper the diet suddenly. We want to do that gradually over time to make sure that the patient's seizures are well controlled. So in conclusion, evidence continues to accumulate to support the use of ketogenic diet therapies for adults with epilepsy. Rigorous randomized clinical trials are needed to determine optimal ketogenic diet therapy choice based on underlying seizure disorder or epilepsy syndrome. And in clinical practice, optimal ketogenic diet therapy management is tailored to the individual. Here are my acknowledgements, and that is to the Johns Hopkins Adult Epilepsy Diet Center, our patients and their families, as well as my national and international collaborators, particularly Susan Wood, who is involved in the international recommendations that I have presented today, and my funding sources. And thank you to all of you.